I have to confess that actually there's no data. So in the heels of a recent US election, what I'll be using is making up statistics, and we can certainly play a game where you try to guess which statistics is right. But unfortunately, from the look on Dr. Sanyal's face, we'll forgo the game and just focus on evidence-based medicine. So in order for us to understand how to manage patients in the post-transplant period, we have to understand how the patient got there. And to do that, we actually have to look at recent trends in liver transplantation. And as physicians, all of our goals is to improve morbidity and mortality in our patients. And the way we can do that is to first actually understand what are the causes of morbidity and mortality in these patients. So we'll talk a little bit about that, and then focus on how can we optimize management in these patients to improve morbidity and mortality, focusing on mortality. And as I'm talking about these topics, I'll be focusing on how we can optimize care, particularly based on immunosuppression, which is a major risk factor for a number of disease processes that patients with NASH are at risk for after liver transplantation. Now, most of you know this, so this is a review. NASH is not, or fat liver disease is not a disease that only affects the liver. It's a multi-system disease that's associated with obesity, as you have heard before, dyslipidemia, insulin resistance to diabetes, and hypertension. So NAFLD doesn't exist in isolation. What happens with NAFLD as patients develop these disease, they are seen in, and I think NAFLD represents a perfect cheese model for medical care, because it's a disease that's highly prevalent, affecting 1 in 3 or 1 in 4 Americans. There is no effective screening tools, either cost-effective or accurate, in primary care setting. It doesn't have to be associated with liver enzyme elevation. Actually, in fact, what you and I are hepatologists as used to as abnormal liver enzymes, which are, for instance, in women more than 19 or 21, are not what's reported nationally in commercial laboratory. At level of 40 to 60 is considered abnormal when we clearly know that's not abnormal. And we have shown that patients, 30% of patients who have suspected NAFLD actually have liver enzyme elevation between what is abnormal and what's reported by commercial laboratories. And since they don't have any pathognomonic features or symptoms, this disease often goes unnoticed. What that means for the transplant community and hepatologists is the time that we're making contact with this patient. Our first contact may be when many of these patients have already developed cirrhosis, or they're presenting with their first decompensating event. And what that essentially translates into is that we have lost the ability to intervene on this disease process and change the natural history and what happens to this patient. What we're left with is liver transplantation, which you have seen this slide before. Dr. Puri showed it to you, is that NASH as a listing diagnosis is increasing rapidly compared to all other etiologies. This is because we're detecting the disease far too late, where there's no role for intervention with the exception of liver transplantation. Now, as patients progress along the histological spectrum, they tend to develop medical comorbidities, and that can be present in the presence of atherosclerotic coronary heart disease, renal insufficiency, heart failure, whether it's systolic or diastolic, arrhythmias, and so on. And eventually, patients get to cirrhosis. Once we are seeing them as transplant hepatologists in clinic, decompensated cirrhotic, what we do is we actually give them a liver transplant, and what we have done instantaneously is fix the liver problem. They have a fully functional liver, but what we haven't fixed is all these other comorbidities that they came with. So it should be as no surprise, and this was presented this year at the meeting, that majority of these patients, close to 90% of patients develop non-alcoholic fatty liver disease after liver transplantation, after median follow-up of almost 9 years. Not only that, but 45% of these patients develop non-alcoholic steatohepatitis, and about a quarter of these patients develop advanced fibrosis characterized by F3 to F4. Much like the pre-transplant population of the general public, ALT in this patient population does not predict disease recurrence, does not differentiate between NAFLD and NASH, and does not differentiate between the various fibrosis stages. So ALT, for all practical purposes, is a useless test for looking at NASH after transplantation. Now, this shows survival curves in liver transplant recipients, and it should come as no surprise to this audience that long-term survival has been improving in the US. In fact, this is likely multifactorial. partly owing to improvement in surgical technique, anesthesia care, improvements in chronic immunosuppression, infection control, and so on. So we are actually enjoying the best survival rates that we have in the past. But that's just not good enough, because if you compare long-term survival rates in transplant patients to the general population, there's a 2.5-fold increase in mortality among liver transplant recipients. What that means is there is still work left for us to do. So let's understand this causes of long-term mortality, and this is a multi-center cohort. And you can see, and this is going to change because recurrent liver disease is not going to be a major cause of mortality in patients with NASH. And NASH, as speakers before me have shown, is an increasingly common indication for liver transplantation. So almost 3/4 of individuals die from non-recurrent liver disease. And what comprises the majority of these is malignancy, cardiovascular disease, and infection. Additionally, the 13% of patients who suddenly died in a well-characterized cohort likely had underlying coronary disease or sudden cardiac death, which further compounds the cardiovascular-related mortality. Now, what about NASH patients? And this is, once again, the data that we presented at this meeting. It's a very similar picture. Actually, less than 10% of patients transplanted for NASH are dying from recurrent graft cirrhosis after 20 years of follow-up. What they're dying of are cancers, infection, heart disease, kidney disease. So another way to look at this exact same pie graph is to look at it like this. About 3/4 of these patients are dying from medical conditions that are potentially impacted by chronic immunosuppression. So the question at hand is, how do we minimize this, and how do we take care of this? So how to take care of a post-transplant NASH patient can be divided up into 3 separate categories, and it begins with pre-transplant care. We have to be very careful in the patients we select. There has to be evaluation of their BMI, cardiovascular status. If you have a patient with a BMI of 65 who has uncontrolled diabetes, has extensive coronary artery disease, is likely not going to do well after transplant. Actually, likely it's not going to do well before transplant, but that's beside the point. Then there's strategies at the time of transplant that can be done to minimize complications associated with transplantation. And these focused on using steroid-free or reduced steroid regimens, renal protective protocols, and management of hyperglycemia. However, the focus of this talk are not pre- and peri-transplant management, it's the post-transplant management. And in order for us to delineate that, we have to understand what are goals of chronic immunosuppression. So the goals of chronic immunosuppression is, first, reduce the risk of rejection in patients. Second is to limit complications associated with chronic immunosuppression. And third is to actually reduce disease recurrence in these patients. And I'll be the first to admit, we don't actually know anything about disease recurrence and how metabolic factors play into that. All the information that we have is extrapolated from non-transplant population or the general population. So we can apply similar themes to it, but I don't have any data to back up what I'm saying. Now, you can break down consequences of long-term immunosuppression in 4 major categories. There's metabolic complications, which include type 2 diabetes, hypertension, obesity, hyperlipidemia. That's important because it leads into cardiovascular disease. There's risk of renal disease, chronic renal insufficiency in liver transplant recipients who transplant for NASH, and de novo malignancy. I'm not going to really focus in on malignancy because each one of these is a significant talk, and with limited time, I'm going to focus on metabolic syndrome, cardiovascular disease, and renal disease. Now, this shows metabolic syndrome in the general public. It affects nearly 25% of the general population. In liver transplant, that number is doubled. And there are some studies that even quote as high as 2/3 of patients will have metabolic syndrome after liver transplantation. This slide shows when they actually develop metabolic syndrome, and most patients are developing metabolic syndrome early, within the first year after liver transplantation, and the prevalence and incidence continues to rise. However, it's less steep than it is in the early period, which means the time to intervene and change the disease course, the disease activity, is this early within the first year after liver transplantation. Now, why do we care about metabolic syndrome? We care about metabolic syndrome because it predicts cardiovascular events and cardiovascular mortality, which is what this graph shows. Patients who have metabolic syndrome have decreased survival compared to those who do not. But more importantly, these curves start to separate after 10 years of follow-up. Now, if you look at a similar graph in liver transplant recipients, the data is striking because it shows that that graph actually separates within first year after liver transplantation. And secondarily, the differences between the two lines are striking. Now, this is showing just vascular events, but I can show you similar data that shows post-transplant mortality as a function of post-transplant metabolic syndrome, and is significantly higher in that patient population. And this slide shows the risk of cardiovascular events that are enumerated based on time from follow-up. And regardless of which event you want to focus on, whether it's coronary artery disease, myocardial infarction, sudden cardiac death, arrhythmias, they all increase, and that's a time-dependent increase. Some of these are potentially the risk could be reduced or minimized, and we'll talk a little bit more about that. So let's focus by talking about components of metabolic syndrome in liver transplant recipient. This slide shows the prevalence in all liver transplant recipients after transplantation. And as you can see, the risk of diabetes is roughly 30 to 40%, obesity is about 50%, hypertension is about 50 to 75%, dyslipidemia is about 40 to 60%. This is all comers, not NASH. When you look at NASH, these numbers are astronomical. It's literally metabolic syndrome on steroids, no pun intended. So the risk of diabetes is about 75, 80%. Risk of obesity is 60% in NASH patients. Hypertension is a staggering 90%. And dyslipidemia is a staggering 85%. So this goes back to the slide that I initially showed you. We get rid of the liver, we get rid of the defective organ, but we don't get rid of the defective medical problems that they came in. Okay. Now, let's start by talking about weight after liver transplantation. This is an interesting study because it illustrates several points. So what it did, it actually stratified patients based on weight categories. So at the time of transplant, so there's 4 categories: patients who were underweight, BMI less than 18.5, optimum weight, BMI of 20 to 25, overweight, BMI of 25 to 30, and then obese, BMI of greater than 30. There's a couple of things that you can see. The first is that there is a time-dependent increased weight gain in all groups, and that weight gain is actually most rapid within the first 2 years after transplantation. Secondly, 16% of patients who were underweight to begin with gain enough weight that they become obese. 26% of normal weight individuals become obese, and the weight gain in individuals who are overweight and obese continues to rise. Now, we all know that steroids tend to cause weight gain, but most centers have gotten away from using steroids or using reduced steroid regimens. What about CNI? Calcineurin inhibitors are the backbone of immunosuppression at this point. And there is a statistically significant difference in weight gain after transplantation in patients who are taking cyclosporin compared to tacrolimus. However, if you look at follow-up at 3 years, there's no statistically significant difference. So it doesn't matter what regimen you're using after 2 years, the weight gain is similar between the two. Now, there are some strategies that have been used that actually reduces weight gain in these patients, and that employs using low-dose CNI coupled with mTOR inhibitors, and the weight gain was less than full-dose tacrolimus, for instance. Now, this shows post-transplant diabetes, and all transplant hepatologists and surgeons are concerned about 2 things: patient survival and graft survival. And this slide shows that patient survival and graft survival is decreased in patients who have underlying diabetes. So the line marked by number 4 is the one that are normal, and then there's various other lines. Line 2 suggests patients who had sustained diabetes after transplant. And it should come as no surprise to any of us that patients who have diabetes don't do as well as patients who do not have diabetes. However, there's an interesting group, which is group number 3, and this is these are the cohort that actually developed transient diabetes. So they had diabetes for more than 1 month, but less than 6 months. And there's a significant difference in this patient population with regards to both patient survival and graft survival. And this likely represents underlying glucose intolerance that was not picked up by the current methods of diagnosing diabetes. And the reason why diabetes is important is because of this. If you have age, gender matched individuals and the time when they were transplanted, Development of post-transplant diabetes is associated with a litany of medical conditions, including increased cardiovascular mortality, cardiovascular disease, infections, neurological problems, neuropsychiatric problems, and end-stage renal disease. So this is why we want to prevent this in the first place, if we're able to. If not, control it so we can change some of these numbers and return them to non-diabetic levels. Now, we all know that tacrolimus is associated with increased incidence of post-transplant diabetes, and this shows that statistically. And why this happens? Now, there's a couple of theories, but I'm just going to walk you through one of them, is that cyclosporin exposure or tacrolimus exposure is associated with decreased basal insulin secretion, thereby increasing the propensity for developing diabetes. When exposed to tacrolimus, glucose-stimulated insulin secretion drops by nearly 80%. However, in cyclosporin, it drops as well, but the drop is not as profound, and it's only 50%. And that's why what we end up seeing, and this beta cell content was not affected. So the changes that we're seeing are independent of beta cell mass or content or function. What we're really seeing is decreased secretion. So it should come as no surprise that in this Cochrane review, tacrolimus use was associated with higher risk of de novo diabetes requiring insulin. Now, post-transplant dyslipidemia is characterized by similar thing as it's in the general population: decreased HDL, increased triglycerides, cholesterol, and LDL. Cyclosporin use has been associated with increased LDL cholesterol, total cholesterol, and triglyceride. Cyclosporin is not associated with any changes in HDL cholesterol. And this shows that when cyclosporin is stopped, there's a reduction in total cholesterol, LDL cholesterol, and triglycerides, and it does not impact HDL cholesterol. Why that happens? There's multiple in vitro mechanistic explanation for them. Some of them involve that cyclosporin inhibits the rate-limiting step in bile acid synthesis. It affects VLDL secretion out of the liver, or increases VLDL secretion. It affects LDL receptor activity, so more cholesterol is floating around and not taken up. And regardless, what the clinical phenotype that produces ends up is cyclosporin use is associated with more dyslipidemia. And actually switching from cyclosporin to tacrolimus is a way of reducing lipid in patients who develop dyslipidemia and cyclosporin therapy. And this shows that the bars left of the red dotted line are patients who are on cyclosporin. And after the switch is made, you can see there's a reduction in total cholesterol and triglycerides. I'm not showing the data for LDL, but a similar reduction was noted in that. However, there was no impact on HDL. Now, there's a growing body of literature that suggests that the traditional lipid profile does not truly capture the atherogenic risk, and that lipid subparticles may actually better predict the risk of coronary events in patients with liver disease. One of these candidate lipoprotein subparticle is small dense LDL, which is a highly atherogenic particle. So what we show is that patients who are age, gender, and BMI match who've had a transplant have a considerably high levels of small dense LDL when compared to non-transplant population. Now, that effect is exaggerated even further in liver transplant recipients who have steatosis on biopsy compared to those who do not. And finally, if you look at those patients who have steatosis on biopsy and are taking cyclosporin, that's the group where small dense LDL is at the highest. Now, this is an association and not causality, but it underscores the point that repeatedly cyclosporin use has been associated with more proatherogenic dyslipidemia. Transitioning into hypertension after transplant, in patients who may have hypertension, their hypertension can improve as they progress to decompensated cirrhosis for a multitude of reasons, one of them being that there's a decrease in systemic vascular tone. As they undergo a transplant, that changes rapidly, and the cardiac output and index decreases, systemic vascular resistance increase, and then we see a subsequent increase in their mean arterial pressure and the risk of developing hypertension. There's multiple other factors that play into it, including CNI use and the dose of CNI use. Now, in the past, when we were not cognizant of this fact that patients were going to develop significant hypertension, it wasn't managed well. And a significant number of patients after liver transplantation developed severe hypertension and led to complications, including myocardial disease, myocardial infarctions, cardiac damage, end-stage renal disease, stroke, and neurocognitive dysfunction. However, we are more cognizant of the fact that patients are at risk for developing hypertension, and in this day and age, likely to developing refractory or severe hypertension is only about 10%. Uncontrolled hypertension can lead to chronic renal injury. And this is a Sentinel paper that shows the risk of developing chronic renal injury after liver transplantation. And liver transplantation, of all the solid organ transplantation aside from intestinal transplant, poses the highest risk of chronic renal insufficiency. If you focus in patients with NASH, what you start to see is that GFR starts to decrease as early as 3 months in patients that is independent of BMI, age, immunosuppression exposure, and other factors. And it continues to worsen actually after transplantation. Strategies that have been used, and not necessarily in NASH patient, is to reduce CNI and combine with mTOR inhibitors, and that's produced some modest results. But once again, as I showed you before, that this is not a simple isolated problem. This is a systemic problem. And for you to manage a systemic problem, you cannot just change immunosuppression. You have to manage their diabetes better. You have to manage their hypertension better. You have to manage their obesity better. All risk factors, which as you saw from prior slides, liver transplant patients who've had it for NASH are at extremely high risk for. Now, what we worry about, and the reason why we use immunosuppressant, is because of rate of rejection. There's estimated rate of rejection in liver transplant recipients is generally reported between 10 and 40, and 40 is some of the older data. With improvement in immunosuppression, that rate has come down considerably. The rate of chronic rejection is reported about 5%. Now, in our cohort of patients, the rate of acute rejection, and this was actually, most of it was early, was about 12.3%, reflecting what we see in literature. But surprisingly, there was not a single case of chronic rejection in any of these patients. Additionally, most patients developed early acute rejection, defined by rejection happening within the first 6 months. And the only patients who developed rejection after the first year after transplantation were grossly non-compliant, and once their immunosuppressions were reinstituted, their liver enzymes improved. This slide summarizes medical comorbidities associated with immunosuppression, and it breaks it down based on the type of immunosuppression. As you can see, calcineurin inhibitors, which are the backbone of immunosuppression therapy at this day and age, increases the risk of diabetes, hypertension, dyslipidemia, malignancy, renal injury, and weight. So we have to use this. We're stuck with this almost a necessary evil. However, what we can use is strategies to minimize calcineurin inhibitors and combine it with other things so we can exploit potential benefit. For instance, if somebody's developing recurrent skin cancer, mTOR inhibitors may be a reasonable option in those patients, and so on. Now, I'm going to bring you back to this slide, which is what I started the conversation with. And this shows that the transplanted liver in a patient who has metabolic comorbidities. And it's really naive for us to think that we can change immunosuppression and control all these metabolic comorbidities, because the reality is that will not happen. So what we need is a partnership between the hepatologist and primary care physician. So I'd like to think that most of us have, at least in our mind, the way we think about it is the hepatologist will manage immunosuppression and risk of liver disease, while the primary care physician will help manage other medical comorbidities. The reality is far from that. And this is a national survey of primary care physicians, which shows a fair number of primary care physicians just do not feel comfortable managing post-liver transplant patients. In fact, almost 10% of them will defer all care to transplant centers. About half of them will have a continuous dialogue with the transplant center to help manage this. So what this essentially starts looking like is there's a significant overlap in the care that we as transplant hepatologists provide compared to what the primary care provide, which is okay, because ultimately the goal of the care that we're providing is not that we're treating diabetes, obesity, hypertension, is that we're focused and we are invested in outcomes of our patients. So it's not okay to have a patient who comes in and sees us repeatedly whose blood pressure is running at 150/90, or who has a fasting blood glucose level that's been creeping up and is 135 for the last 3 visits. We have to do this in conjunction with primary care physician. And that's the way to optimize management. I would even condone that when patients are being evaluated for liver transplantation, we see and make sure that they have good primary care physicians so that they can help us take care of the patients after liver transplantations. Because if we don't do that, and these metabolic complications, which is what the majority of these causes of mortality are in these patients, are not done properly, we compromise the care that we provide these patients. So to summarize the findings, subjects transplanted for NASH are at high risk for developing metabolic complication and recurrent disease. Cardiovascular disease, cancers, and infectious complications are important causes of long-term mortality in liver transplant recipients. Liver transplant recipients are at low risk for developing acute rejection and don't really develop chronic rejection, at least in our case series. And then immunosuppression strategies in these patients should be individualized. There is no one-size-fits-all. And we have to focus on reducing CNI doses. Now, the optimal levels are unknown, and if you ask 3 different hepatologists, you'll get 9 different answers. But no one is right, no one is wrong. It's just a matter of what works best for the patient. And then we have to use combination strategies so we can exploit some of the potential benefits of other therapy. And with that, I'll end my talk. And open it up.